Hey, deserving listeners, I thought I would just respond to a patron email, an interesting one. This is the Psychology in Seattle podcast. I'm your host, Dr. Kirk Honda. I am a professor and I'm also a licensed marriage and family therapist. This email is from patron Ryan. And if you haven't already, please become a patron of the podcast. That's not part of the email. That's just me saying, if you haven't already, become a patron of the podcast and become a part of our little team of deserving listeners. All right, this email's from patron Ryan. I'm a longtime listener and recent patron of the podcast. I love the great work you guys are doing and even assigned certain episodes to my students as extra credit. I can't remember if it was the psychology myths episode or the defense mechanisms episode, but I remember that conversion disorder was brought up. This reminded me of an encounter I had, and I figured you'd be interested in it. Prior to me returning to get my PhD, well, la-ti-da, patron Ryan, PhD, good for you. Prior to me returning to get my PhD, I was a master's level counselor in a psychiatric outpatient program and was on call with the emergency department. One of my calls was about a woman who inexplicably lost the ability to walk and was functionally paralyzed below the waist. Numerous medical consults ruled out any physical explanations. This patient was quite depressed and told me about how she had a gambling and compulsive spending problem, which led to her family cutting her off from her funds. She became depressed and slowly started losing functioning of her legs. With antidepressant medication and therapy, she eventually started walking again. Also, I loved your episode on the study you conducted about seasoned psychotherapist experience of difficult clinical moments. I wonder if you've thought about publishing it if you haven't already. It would make a great contribution to the literature, in my opinion. Well, thank you, patron Ryan. That's nice of you to say. And I always love getting emails like this from clinicians of stories because, it's a very interesting story. They're saying, this woman comes in, she's paralyzed, and she is evaluated medically, and they can't figure out why she's paralyzed. And then some astute clinician decides to refer this person to a counselor or a psychiatrist or whomever, and then patron Ryan starts talking with her, and they put her on antidepressants, and they give her some talk therapy, and lo and behold, her paralysis subsides or recedes or goes away. So it's just a fascinating story. It sounds crazy to some people, I'm sure, but to us in our field, it's understandable because the mind can do all sorts of things, and stress and trauma can do all sorts of things, including paralysis. But anyway, at the end of your email, you're asking me, am I thinking about getting it published? My dissertation was on seasoned psychotherapist experience of difficult clinical moments. You can listen to that episode if you want. And I have considered publishing it, and people will often say I should publish it, either as a book or as a journal article. And to tell you the truth, I have a kind of funny relationship with publishing. I am supposed to be very interested in it as a professor. Professors are supposed to be always publishing, right? Publish or perish. But at my university, we focus mainly on the training of therapists rather than on publishing. We're encouraged to publish, and we're given time to do so. But we won't lose our job if we don't publish. And we don't really have a huge culture of publishing. People do it, but some people don't. And so that's one factor. Another factor is that it's very time consuming to get published. And although it's probably not as time consuming to take a dissertation, just reduce it down to the length of a journal article and just start, shopping it around to different journals. And as I say it out loud, I'm thinking, why haven't I done it? But I have a lot of colleagues that publish a lot, and I just have witnessed the frustration and the time that they put into it. And I have a limited amount of time left on this planet, and I have a lot of things I want to do, but there are certain things that have to not be pursued in the interest of doing other things like this podcast, for instance. I love doing the podcast and consider it to be not only just personally fun, but also it's a publishing of sorts. I'm getting word out there to people about things that I believe will help the profession and help humanity. I know that sounds completely grandiose and ridiculous, but that's the purpose of publishing. When you publish something in a journal article, in a journal, you're trying to add new knowledge to the field, and you're also just trying to, in my opinion, you're trying to make the world a better place. By adding knowledge, presumably it will lead to our ability to reduce suffering and to further our race of humans. And so this podcast does that. It's not traditional, and it's not respected in the academic world for sure, but in essence, that's what I'm doing, and I'm going to reach far more people on this podcast than I ever would if I were to, for instance, let me just sort of break it down. Like if I were to, do a deep dive on a particular topic, like I often will do for this podcast anyway, and then at the end of that deep dive, I start writing something, and I conduct research, and I start shopping it around to different journals and begging them to put it in their journal, and just becoming, rejected. And because I know people that have excellent articles and research teams of excellent psychologists and other researchers who have conducted excellent research on things like resilience and other kinds of things, and they cannot manage to get it published anywhere. And it's just, it's terrible. It's like you're begging someone to publish it. It just doesn't make any sense to me. And there's a lot of elitism and just a lot of silliness. But anyway, so I could probably spend 6 months of my free time doing that and still not get it published. And usually it's more than that, but say 6 months of like dedicated free time. Well, think about how many podcast episodes, good quality podcast episodes, I could produce in 6 months with that time, or 12 months or whatever. Yeah, I could so match that up with how many people are going to read that journal article if I get it published. A small amount of people will put their eyes on that, whereas the podcast gets presumably listened to by tens of thousands of people, including the lay public, which is not that you're out, when you publish something in a journal, the lay public rarely reads that. Clinicians rarely read it for that matter, and researchers rarely come across it. But so the spirit behind publishing and psychology, I feel like I'm achieving that goal in the podcast. But anyway, having said all that, publishing in journals is an absolutely worthy activity to do. For those that do it, it's a invaluable process in our field and in other disciplines, because it has mechanisms in it that provide a sort of checks and balances. For instance, when I do this podcast, I don't run it by anybody before I publish it usually, and so it's just me and my own biases and my own foibles making a podcast. Whereas when you publish in a journal, you have lots of eyes on it. You scrutinize it yourself. The journal will have editors that will look it over and check your math sometimes, maybe even look at your data and say, oh, you made a mistake here. Go back to the drawing board and work on this, and then come back. And so when something's in a journal, in general, this is absolutely not true all the time if you really look into it, but in general, the practice and the culture is such that once it gets published in a journal, especially the highly respected ones, you can it's been vetted, and it isn't just some guy in a room yammering into a microphone. It's actually legit in a sense. I don't have good words for that, but so, I'm not going to say that the podcast is the same as that at all, because it's not at all. But, yeah. So, but to answer your question, yes, I should get it. I should probably get it published, because when it's a dissertation, it only has a limited amount of eyes on it, and if I manage to get it into a journal, it's more likely to be seen by other researchers and referenced by other researchers and stuff. And the findings of that study, I think, are useful for our field in that it normalizes therapists' reactions to difficult moments. It humanizes therapists and says it's okay that you have freakouts as a therapist when a client presents a difficult situation for you. But anyway, getting to your conversion disorder thing, I thought I might just do a little bit of talk about conversion disorder and the history. Conversion disorder, for those of you that don't know, is when psychological stress manifests in a physical manner. So you're really stressed out about, your job, and you develop blindness. So because of a psychological stress or trauma, you have a physiological symptom as a result. In essence, you're converting psychological stress into a physical manifestation. Freud coined the term long ago, and basically he believed that psychic stress is defensively converted into a somatic symptom because the ego doesn't have a way of functionally expressing the feeling that needs to be expressed. That's just in a nutshell. Conversion disorder is seen today often as numbness in a part of the body, or blindness, like I said, or paralysis of a particular part of the body, loss of speech, or a strange pain in a part of the body. As I was saying earlier, you can never underestimate the power of the mind to do strange things, particularly when it's stressed out. And one of the manifestations of stress is to have a very distinct physiological symptom. And when you ask the person that has converted their stress into blindness, when you do tests on them, they're functionally blind. They're not faking it. Or when they're paralyzed from the waist down, even though it's quote unquote, what often is called psychosomatic, but that's not a helpful term. It's a better term is psychogenic or conversion. And it's real. It's not, they're not faking it. Just because it's from psychological stress doesn't mean that it doesn't exist. It totally exists. The paralysis is real, and the patient doesn't have any control over that. It's the unconscious doing its work. So also, never underestimate the power of culture. In different cultures, conversion disorder shows up with different prevalence, meaning that, or speculating, we can speculate that in different cultures, different ideas are spread throughout the culture non-verbally that suggest to the subconscious or the unconscious that different ways of defending against difficult feelings. For instance, there are, I don't know that much about it, but there's people in Southeast Asia, I believe, men who believe that their penises are gone. They believe, I don't know if this is apocryphal, but I remember reading somewhere that there is a whole mental disorder in Southeast Asia that doesn't exist anywhere else in the world, in which men, presumably when they're stressed or traumatized, they will have a delusion that their penis has been taken by someone else. I don't know if it's like a magical kind of thinking or something, but they will look down into their crotch and they won't see a penis, even though there is a penis there. And there's a whole kind of mental health industry around that, I think, in Southeast Asia, Vietnam, I think. Anyway, so that all could be wrong, but the point is that in different cultures, you will find different rates of conversion disorder, different times. I believe, although the research, can't really look into this because over time we haven't conducted this sort of research very well, but Conversion disorder seems to be something that was prevalent in the Western world 100 years ago, much more than it is today. People today, when they're stressed out, have other ways of culturally expressing their stress, whereas 100 years ago, converting it into blindness or paralysis was more prevalent because you just had this idea of that's what you do when you're stressed out. And again, it's not a choice that people make. It's not like, oh, this is the allowed cultural way of expressing stress. No, it's unconscious. You pick up on these cues from the outside world and from other humans' behavior, and your subconscious learns from that and will use that as a tool when it needs to. I hope that makes sense to you, but I don't know if it came out quite eloquent. Also, it should be said that when we are diagnosing someone with conversion disorder, we have to always be tentative, because just because we can't identify a biological quote unquote cause of the paralysis or the blindness or whatever, doesn't mean that there isn't a biological cause. Now, some people will say, the mind is biological, and if it's quote unquote causing the blindness or paralysis or numbness or whatever, then it is a biological cause. But I think you get what I'm saying. When someone comes into the hospital and they are paralyzed from the waist down and they can't find any nerve damage or any kind of biological reason for it, then they will start wondering if it's psychogenic. And whenever we identify it, then again, we just have to be tentative, because we just don't have the science to really understand and pinpoint things that things like this. Things like what do they call it? Chronic fatigue syndrome. These kinds of things. It's like these kinds of syndromes point to the fact that our science just isn't as good as it needs to be in order to really figure out what's happening for these people. And so, now when someone comes in, like with patron Ryan's patient, and they have a history of stress, and you give them antidepressants and talk therapy, and the paralysis goes away, then you can tentatively say they likely were suffering from conversion disorder. But it's unknown, because the symptoms could have subsided just coincidentally with the talk therapy and the antidepressants. So that's always something that I think about when I think of conversion disorder. Having said that, I've never treated conversion disorder. It's not a very common thing, and it's not a common thing that someone like me would see in a private practice setting. So I'll just put that out there, that I'm not an expert on it. But anyway, the history of conversion disorder is interesting, I think. So you have Jean Martin, I'm guessing, French guy, Charcot, neurologist, late 1800s in Paris, I believe. Charcot, he specialized in treating patients who were suffering from conversion disorder, which was somewhat of a new field at the time. Psychology and all that stuff was emerging in the 1800s. Conversion disorder was also called hysteria at the time, and I could go into a long talk about the history of hysteria. It's actually really interesting. It goes back to, I think, the Greeks, and they thought that the uterus in women was moving around the body, and that, hyster is the Greek word for uterus, hysterectomy, that kind of thing. And so hysteria was like, there was the uterus was moving around, and so they had to use different, they would try to coax the uterus back to the vagina by putting nice smelling things by the woman's vagina, and by putting things that smelled bad by the woman's mouth and nose, because it was trying to, I guess, scare the uterus back. I'm not even joking. This is true. And they believed that when women had psychological problems or symptoms of some sort, that it was a problem with the uterus, and so they treated it this way. I just always wondered, how did they come up with that? Because it's not like they did an autopsy and found that the woman's uterus was up by her throat. It's like they just had this idea that maybe it's moving around. It's so interesting. They also, I think, thought that women who didn't get to have orgasm or weren't having enough orgasms, that this led to hysteria, which, I could almost understand to some extent. But anyway, so fast forward thousands of years to the 1800s in Europe, and they're using this hysteria word. I don't think they believed that it had anything to do with the uterus directly, but they were still using that word, I think, because it had been passed down through the generations again. But okay, so Charcot was treating people with hysteria, aka conversion disorder, and Freud came to Charcot before Freud was Freud. He was trying various different ways of furthering his career and not having much success. And then he comes across Charcot and observes Charcot working with conversion disorder, and how Charcot believed that it was related to psychological stress and trauma. And Freud was like, well, it's brilliant. And then Freud began developing his own theory regarding trauma and how it led to psychological stress and how it led to somatic symptoms. Incidentally, later on he would abandon this idea of trauma leading to psychological stress, but he was right. He was right in the beginning. He should have stuck with, because eventually it became all about sex and about suppression of urges to have sex with your parents. And, it became quite odd, honestly, in my opinion. He started out great, I think, and then I don't know what happened along the way. But Freud's very interesting. Like, when you study him, it's almost like he said everything that was ever going to be said about our field. If you're looking for, if anything that is talked about today, you can go back to Freud and find he talked about it. He might have later refuted his own sayings later on, but he had a long career of saying a lot of different things, and so it's just interesting. Anyway, so Freud then worked with Anna O, the famous Anna O, with his mentor Joseph Breuer. Anna O is the code name for Bertha Pappenheim. I've talked about this whole situation in other podcasts, I think about countertransference maybe. Anyway, Freud was working with his mentor Breuer, and Breuer was treating Anna O, or Bertha Pappenheim. And experts now, looking back at Bertha's symptoms, believe she was suffering from the stress of her father becoming ill and then her father dying. She was very close to her father and was taking care of her father as he was ill, and then when he died, it was very stressful for her. And she developed a number of symptoms around this time, like the paralysis in parts of her body, and troubles with her vision, troubles with her hearing, troubles with speaking. And she would become unconscious at times, and she would also hallucinate. So she had a lot of different symptoms. And again, we have no way of knowing if she was converting. She might have been suffering from some neurological disorder of some kind, but at the time, at least, and many people even today still believe that it was psychological stress that was leading to these things. And Breuer and Freud, they thought, well, maybe it's hysteria or conversion disorder. And Breuer was desperately trying to help Bertha Pappenheim, with her stress and her symptoms. And over time, Breuer and Pappenheim they both discovered together that when Pappenheim was given the chance to talk about her experience, her symptoms decreased. She described it as chimney sweeping. She's sweeping the chimney of her brain. And she also referred to it as the talking cure. Now, presumably this is all in Austrian, so it's not the exact words. It's, translated in English as chimney sweeping and talking cure. But this became the basis of the entire field of psychotherapy and counseling, and marriage and family therapy was birthed in this, in that time between Breuer, who was Freud's mentor, and Bertha Pappenheim. And really, you could attribute it to Pappenheim herself as the patient. She was just a 21-year-old kid who was, stressed out, but she was the one who was telling her physician, Breuer, hey, it's great when you just let me talk and you just listen to me. It actually it reduces my symptoms. Let's do more of that. And then Freud observed that. And then Breuer had a ton of countertransference, and there was some erotic issues between the two of them. I don't think they ever had sex, but Pappenheim, I think, might have fallen in love with Breuer, and the whole thing exploded. And then Breuer's wife forced Breuer to end the relationship with Pappenheim. And then Breuer said, that was so difficult, I quit the whole field of psychiatry. I don't want to do it anymore. And so Breuer's very short-lived career in talk therapy was with that. And then Freud observed all of that and learned from it, and then used that as the basis of psychoanalysis, which became the basis of our entire field. So conversion disorder is a part of the foundation of our field, which I think is very interesting. All right, well, that does it for this episode of Psychology in Seattle. Thanks for joining me. If you haven't already, please become a patron of the podcast by going to patreon.com. That's patreon.com. Go to our page, Psychology in Seattle, and pledge. And when you do so, you get access to our premium episodes, and you also know that 20% of your pledge goes towards different charities that we support. So you know that you're doing a good thing for society. Okay, please take care of yourself out there, because you deserve it, because you are deserving listeners.